my dear professor. My case is a simple case, but I think a big message is behind. A 32-year-old female, single, not working, presented to our clinic complaining of generalized malaise, anorexia, and weight loss during the last few months. The patient was diagnosed as having type 1 diabetes 13 years ago. And shortly after that, she was discovered to have Hashimoto's thyroiditis and hypothyroidism. Premixed insulin and L-tyroxine therapy were prescribed to her with very infrequent follow-up. On presentation, patient was receiving premixed insulin, 60 units before breakfast only, and the patient omitted a night dose from herself 3 to 4 years ago because of frequent hypoglycemia at night. She was also receiving L-tyroxine therapy, 100 micrograms per day, and vitamin B12. The patient father has type 2 diabetes over 30 years and on insulin therapy. Examination of the patient revealed her body weight was 80 kilograms and a body mass index around 27. Her height was 170 centimeters. Pulse was 70 beats per minute and her blood pressure was 120 over 80 millimeter mercury. Other general and systemic examination showed no abnormality. Initial investigation to the patient showed HbA1c was 5.3%, serum creatinine was 1 milligram per deciliter, albumin creatinine ratio was slightly elevated, 55, TSH was 16 micro international unit per milli. She was uncontrolled on this dose of L-tyroxine therapy, and the anti-TPO antibody was elevated. Her lipogram showed triglyceride 140, serum cholesterol 174, and the LDL was 73. Serum calcium was 8.2 milligram per deciliter. It was reduced, and the vitamin B12 was deficient. So we increased the dose of L-tyroxine therapy to 125 micrograms per day. We added calcium and vitamin D replacement therapy. We advised the patient about good nutrition and exercise. Frankly, we referred the patient to a nutritionist. We asked the patient to do self-monitoring of her blood sugar. And after 2 weeks, the patient presented for follow-up, and her self-monitoring of the blood sugar was good, but with infrequent readings of low blood sugar. We reduced the dose of insulin gradually over the next 1.5 months until it reached 15 units per day, with still very good self-monitoring of the blood sugar. Her weight was reduced on the diet and exercise to 74 kilograms. And we did follow-up investigation. It showed TSH was 2.6 micro international unit per milli. It was controlled. HbA1c was 6%. Serum calcium was 9.1 milligram per dc. And at the point we do fasting C-peptide to know the insulin reserve of the patient and the beta cell reserve of the patient, and it was 1.4 nanogram per milli, which is normal. We thought about causes that bring her diabetes very controlled on this low dose of insulin. So we think about hypocortisolism, and we do serum cortisol and the ACTH as a part of autoimmune diseases, and it was normal. Finally, we stopped the insulin and prescribed a metformin, 500 milligrams twice a day, which we reduced to once after 2 months, with still very good self-monitoring of the blood sugar over the next 8 months. And her last HbA1c was 6.2%, which we were done 1 month ago. And her weight reduced to 70 kilograms. So patients seem to have type 2 diabetes, not type 1. And not only type 2 diabetes, but also her diabetes seemed to be going into remission. But the question, can diabetes remit after these 13 years of insulin therapy? Diabetes remission clinical trials, the major studies that talked about diabetes remission in type 2, but maximum duration of diabetic patients in this study was 6 years. But researchers in this study tell us that remission can occur up to 10 years or even more. The most point is beta cell reserve. Is there beta cell reserve in the patient or not? And is the patient reduced weight or not to decrease liver and pancreatic fat? So remission can occur. And the other question, is remission possible in type 1 diabetes? It is a rare condition and very few cases reports about remission in type 1 diabetes using immunosuppressive therapy or other therapies even before. But duration of remission not exceeded 5 years. To take home message, early tight control of diabetes can preserve beta cells for a very long time. Weight reduction via low-calorie diet and exercise is essential for diabetes remission. Regular and strict follow-up of diabetes is mandatory. Type 2 diabetes can occur in very young people, even those with autoimmune diseases, like our patient. Follow-up is mandatory. If you are in doubt about the type of diabetes, insulin therapy is the rule. And there's one thing, this is the exception, it is not the rule. Because her father, who was on insulin therapy, after her daughter stopped insulin, he asked me to stop insulin. But we can't do this. Thank you.